Patient has difficult IV access. This we can. Patient need long-term access like dialysis, like chemotherapy, antibiotic. We can. Patients who have vascular problems, so peripheral arterial disease, septic food, ischemia, renal artery stenosis, aortic thrombosis, aortic dissection, we can help them. Patient who with abscess, collection, obstruction, hydronephrosis, biopsy if needed, we do ablations, we do embolization to treat tumors or fibroids or bleeding, or even to do it as a pre-op embolization for patient who would or plan to do surgery, and that's always hypervascular, so we do pre-op embolization to minimize the amount of blood loss. Patient has got placenta creta, you know what's that means. So with the placenta is embedded within the muscle, or it's going even beyond the uterus, we try to utilize it to minimize the risk of major bleeding. As you know, major bleeding can consume more than 20 units of blood. A patient can die from lacking of blood in the hospitals. IR also will help in terms of fertility for men, that you see it, for female, fallopian tube, recanalization, fibroid, endometrioma, especially cystic endometrioma, feeding tube placement, NG tube, nasogenital tube, testosterone tube, jejunostomy tube, cecal cystostomy, treating clots in the venous line, so IV splitter, venography, thrombectomy for peripheral and central VE. So this is an example of decline. So usually decline is white or purple in color. So decline stands for peripherally inserted central line. Usually the tip of the decline ends distal SVC or at the right atrium. So here you can see it coming from the arm all the way into the right atrial location, and that's normal. How long decline can last? Up to 12 weeks. Okay. What the alternative for decline is Hickman. So Hickman is tunneled under the skin. So this is under the skin. This just the exposed part of the tube is this one. It's bigger. So decline is very small. Very small. It's like 5 French, 6 French. So it's like 2 millimeter. While this one can be up to like 12 French. So 12 it's like 3 to 4 millimeters. So diameter is almost double. So it means that you can give more communication. If the latency, when things are bigger, if the tube stays open for a period. So if the patient needs antibiotic or chemotherapy or whatever things for more than 6 weeks, we offer treatment rather than time. Or patient needs nutrition, patient with anemia, etc. cannot eat or drink, so we give them some hydration and feed. Similar to it is dialysis catheter. We can skin go up to the jugular, and then the jugular we insert to the tip and over alternative to that is port usually placed under the skin, so then we cover the skin, so there is nothing outside. So if you see the patient, there is you cannot see, you only see a scar, circular scar. use the catheter for less than 2 weeks, just use the central line and that will be enough. If it's almost like 6 to 12 weeks, then decline will be a good choice. Longer period, either cannula or implantable or will be a good choice. And these are the indication for using it. When we do our procedure, we always use needles, okay? And we are experts with needles. So needles has usually two types for vascular access. 21 or 18. 21 is used for microcatheter. 18 is the regular one. There is different types of wires. There is hydrophilic wire and hydrophilic wire. The hydrophilic has soap and has a stiff. Non-hydrophilic has also soap and stiff. And that's for different sizes, 0.35, 0.18, and then 0.4, a little smaller. And depends on the stiffness, the hydrophilic, if it's hydrophilic or not, and the stiffness, each wire has its own usage. You can choose, or what, single wire and all procedure. In each procedure, usually we use like 2 to 3 wires. Okay? Very rare situation, we use just single wire. Extremely rare. Catheters depends on the shape we use. So this is a picture of the similar one we saw in the aorta. This is a reverse curve catheter that we saw at the scenic trunk, remember? And this C2 catheter, that's the one we saw at SMA angiogram. And these different shapes of catheters help to negotiate with the anatomy of the artery. So if the catheter is, or if the artery is pointing up, we have to have a catheter that's pointing up. So any catheter to catheterize the aortic root, the aortic arch, it has to be pointing up. This is ABC. You cannot use this catheter to cannulate the heart, the subclavian arch. You cannot. So either 4, 2, and 1. And we do not use 1. Almost never use 1. So each catheter has its own role. So what's a vascular sheath? It's a device that we use it to introduce wire, usually introduce wire catheter inside the system. And on top of the wire and catheter, we can use a balloon, we can use a stent, we can use other, and sometimes we can do injection. But the main indication for the sheath is we have to introduce wire catheter back and forth. When we do our procedure, we use something called Seldinger technique. So Seldinger is the person who, or scientist who describe this technique, which is inserting a needle. After that, you insert the wire, you remove the wire, you remove the needle, and then insert the sheath and keep the sheath placed. So the sheath will be our gate into the artery. We always try to combine fluoroscopic and ultrasound guidance in hoping to maximize the benefit and minimize the injuries. When you do a vascular procedure, you see any kinking or twisting of the artery of the wire, this is a bad sign, and you have to stop the procedure because you might create complication to location. This is the technique how we do it. Usually we use ultrasound guidance. We have to compare ultrasound that we are inside the artery, and then we advance the wire because the wire. Then once the wire in, we set the catheter. You can see the catheter has a little wall system. We do angiography, so we do contrast in the system. We do angioplasty. There are different types of balloons. There's soap, stiff, drug-coated balloon. So this is an example of a patient who has long-term or large segment occlusion and multiple stenosis. We do angioplasty, and you can see the flow is way better So sometimes we have to put the patient's spine from lateral decubitus in order to have safe access. And sometimes we don't have access. Different type of draining catheter available in the market. This is an example of a patient who has a flexion, similar to the one we saw before, and that's the drainage inside. Nephrostomy is placing of a tube inside the renal pelvis in order to decompress the system, especially when it's obstructed, or there is a leak, like urethral leak, so there's injury to the urine, so the urine is leaking outside, so we need to divert the flow of the urine outside the flexion. In the kidney, there is an area called Brudel's plain. The Brudel plain is the least vascular structure, and that's what's preferred to access the nephrostomy. Nephrostomy carry risk of bleeding up to 20%. Okay? So this is a very high risk of bleeding. Okay? Even biopsy can carry up to 20%, which is high. So doing this procedure has to be done by some expert, otherwise patient will end up with complications. And these complications end up with so this is an example of a patient with hypernephrosis. So there is a stone obstructing the urethral junction, and the patient developed hypernephrosis. And this is one of the indications to place a nephrostomy tube. So this is bilateral nephrostomy placed in this patient. Sometimes we place something called nephrourethral stent. So it's a nephrostomy, but with additional tube going all the way to the bladder. And this will help in getting the blood flow, the urine flow all the way down to the bladder and avoiding drainage outside and into the bladder. Cholecystostomy, so we place a tube inside the gallbladder for patients who cannot do surgery, or patient has perforated gallbladder, and we need to wait until the patient do well, and then the patient can do surgery afterwards. FNA of thyroid is quite common, almost every day we do it, especially with guideline 3, 4, there is guidelines for that, and when you start to have a high suspicion if the lesion is solid, if it has a regular feature, non-classification, extra thyroid tissue, that's very high risk for malignancy, and that's estimated risk for malignancy can be up to 90%. So any patient has a risk of more than 5%, we do FNA or biopsy. We biopsy for solid organs, so this is a lesion in the liver, we did biopsy. We do ablation, so that's another tumor. We did ablation of that tumor, and that ablation means that we get to kill it. Is every tumor for ablation? No, not every tumor. So there's a guidelines detailed by scientists what is the proper treatment for such condition. Okay? And there is something called MENAP criteria and other criteria that we use in such patient. Embolization, as we mentioned, we stop the blood flow. So it's a bleeding, it's a tumor, it's something. There is two types of embolization. There is temporary, so it's something we use just for virtually given time, 2 to 3 weeks, few days, that's it. That's include gel foam and clot. Other than that, it's a permanent embolization. So coil, vascular plug, VVA, glue, all these are permanent. So this is example of gel foam. So this is how the gel foam would look like. Okay? We use, by the way, in ENT for packing. When patient has metastasis, we use gel foam to pack it to stop the bleeding. Particles like this one, it's like small glasses, tiny glass particles that we use to block the arteries. Coils is small metal that sometimes also fit with fiber to promote embolization and thrombosis. So this patient has aneurysm into the cystic artery. That aneurysm was treated with embolization with coil, and the reminder of the to have a very immediate transfusion protocol to minimize that. And if you are able to treat that one without compromising the rest of the tissue of the liver, why not? Or the organ, why not? This is what happens. So this is a patient who has a large gastric varices bleeding from some mucosal tissue. This has been treated with you. You can see that's a blue cast inside, and completely stop the bleeding. There's no more blood flow like this one inside the spine. Feeding tube like percutaneous hysterostomy tube. So hysterostomy tube can be placed by IR, by GI, and by surgeon. The idea for hysterostomy tube is to help patients to receive feeding. Complication can happen for any procedure is widely or gastric leak. So that will create peritonitis, will create pneumonia, also liver wall hematoma. And tube can dislodge either out or inside. And when tube dislodge inside, because there is a balloon inside it, you can see it here, the balloon can cause obstruction and cause bad segmentation. Thrombolysis or thrombectomy is a technique used to improve blood flow to the patients. One second. So this is a patient who has a thin defect into the oblique artery and anterior tibial posterior arteries into the heart. So after doing thrombolysis, we restore flow into that artery. When we do thrombolysis, we use alteplase, and the alteplase has a list of contraindications. And these contraindications can be absolute, can be relative. And we always question people how, because it's a nature of concern. So any patient with any history of intracranial hemorrhage contraindication, any patient with brain malformation or malformation somewhere else, that's contraindication. Ischemic stroke, especially when it's recent, that's contraindication. Dissection, bleeding the axis, and recent head trauma. All these are absolute contraindication. What about relative? You can have uncontrolled hypertension, which means your blood pressure around 518. Okay. If you had CPR for more than 10 minutes a day, that's a very good complication. So why do we need to know about CPR versus? Because the patient has PE, and PE sometimes they have obvious strain will end up with heart collapse, and you get to CPR purification, and the patient recover. And then you found that patient has PE, and you give thrombolysis or not. And this is where the discussion of things like that will happen. Most of the time, we will not have discussion, but in such a patient, you will have major discussion. We use a device, adjunctive device with a TVA. So this is ultrasound catheter that injects alteplase plus doing some motion artifact to break the clots. The beauty of the system uses almost 5% of the required dose of the usual one. So the amount of TVA would be very low for the patient. And the risk of complication related to thrombolysis will be very minimal. So this patient has a floating thrombus to the atrium. CT confirmed this filling defect. Patient underwent echoes on one side, and you can see that filling defect is markedly smaller, indicating improvement of blood flow following echoes treatment. Different mechanical and systemic treatment for thrombolysis and thrombectomy. So So this is an example of a patient who has a large thrombus. This large thrombus was retrieved by mechanical thrombectomy. And you can see the variation between pre, the flow in the coronary artery, pre, and post-intervention. Again, pre and post-intervention. When we treat thrombus, you need to remove it completely. Okay? Removing 50-78% will help to improve the flow toward the line, and that will help to restore the pulmonary function. We never expect we're going to have 100% removal of clot because you cannot do it. Okay? But you remove as much as you can without having the patient. What we need is to restore good flow to the lung base. Okay? If you lose like 5% of your lung, who cares? But you're not, I don't want to lose like 80, 90, 100% of that. IVC filter, it's a filter that we place inside the inferior vena cava to prevent clot migration from the legs to the heart. When do we place it? For patients who cannot take anticoagulation. So if you have a clot, that does not mean you will receive a filter. If you have a clot and you cannot take your medication because you have a hematoma, active hematoma at the abdominal wall, patient who had a surgery and has a hematoma, patient who has allergy to this medication, then yes, we can do it. Where do we place it? Just below the renal vein. So that's the right renal vein, that's the left renal vein. This is the ideal location. Okay? This is the left common iliac vein, that's the right common iliac vein. If you've noticed, the contrast on the venous is suboptimal because we want the flow of the flow doesn't go this way, it goes to the heart. Okay? So the flow from the kidney goes this way. So that's why we didn't see contrast inside the kidney. We didn't see contrast in the left common iliac because we inject only from the right common iliac. When do we remove it? As soon as we will need it. We do HSG, hysterosalpingogram, and you can see the fallopian tube on the left side and the right side is very small. So sometimes we need to recanalize this tube when it's obstructed. So patient who has fallopian tube obstruction, we do fallopian tube recanalization. So when do we know patient has fallopian tube obstruction? Patient is infertility. So patient fertility after the workup is to do HSG from that. Another one is you can see there is uptake of contrast into the myometrium. So this is a case of adenomyosis. Do you know what's adenomyosis, by the way? يلا يلا كريم ما شاء الله. ايش الادينومايوسيس؟ وش الفايبرويد؟ حلو؟ جنان متمكن؟ جنان تيومر وين موجود؟ ها؟ بالمايومتريوم، بالمايومتريوم بالمايومتريوم، اوكي؟ لكن باللوكيشن بالمايومتريوم ممكن ينزل تحت، يدفع السبميكوزا أو يطلع برا أو يدخل المايومتريوم، انترميورال سبميكوزا سبسيروز أو ميجور. طيب هذا الفايبرويد، الادينومايوسيس endometrial tissue طالع وين؟ بالمايومتريوم. هذا اسمه برضه الاسم بالعربي شو اسمه بالعربي؟
مهاجر.
ايش؟ يعني هي هذا الاسم المتعارف عليه، اسمه هذا الاسم الصحيح. وش اللغة مهاجر؟ ها؟
Endometriosis.
endometriosis والبطانة مهاجرة. والفايبرويد هو الرماديدي. والدميوسيس؟
تحويل.
لها اسمين، الاسم الأول اسمه العبالة والضدي. عشان هذا الاسم العلمي الصحيح اللي الحين يجيبون ليش سميت كذا؟ أو البطانة مهاجرة محلية. وش البرزنتيشن حكايتهم؟ مين هذه؟ ها؟ الاندوميتريوس تسوي؟ ها؟ تيجي وش؟ طلع شو تمام ما هيفي بليدنج. وش اهم من الهيفي بليدنج؟ بين. ليش تسوي بين؟ سايكليك بين او شيء سايكليك بين. ليش؟ لانه كان غلط. واحد. ثاني شيء لانه لما يصير وقت البيريد طلع بليدنج والبليدنج حقه ما يطلع برا، بليدنج جوا القلب، يعني جوا الاورجن نفسه اللي فيه تيشو. لما نروح للاديمايوسيس، الاديمايوسيس هذه عباره عن نورمال تيشو موجود وما يمكن، والاديمايوسيس يكون فيه دي، لكن لانه ما يمكن يطلع يسوي شيء بالبيريد، ولا شيء تسوي بالبيريد. الادينومايوسيس والفايبرويد they share the same presentation during period, very period with the plants. But مثلا عندنا almost like 30 days of bleeding, which means that continuously. طيب وش ممكن نسوي لهم في سنة الادينومايوسيس بالعين؟ أو الفايبرويد كمان. Embolization هون. شو قال في الآخر يسمى فايبرويد. Protein fibroid الآخر يسمى fibroid عن bilateral. Does this affect fertility? No. For any patient less than 40 doesn't affect fertility. لما نقول كنا radiation يؤثر على وظيفة المبايض غلط. الامبوليزيشن يؤثر على وظيفة المبايض غلط. آخر من 40 سنة ما يأثر. فوق 40 سنة نعم. هذه المعلومة. المعلومة الثانية يحسن من السيمتوم patient. السيمتوم والهذه 3 doesn't require surgery. معناتها recovery faster. الاثنين أقل. في اثنين adenomayosis سابقا إلى 5 سنوات سابقا كثير ترى من الولايات treatment حقهم عندهم 2 treatment. واحد يعطون هرمون ثيرابي يسوونه استروجين. That's it. يعطون علاج OCP أو شيء ضد الجينرالج أو استروجين. الإمبوليزيشن وجدوا 70% من الناس تحسنوا منها، مو زي الفايبرويد البنت لكنه ستيل